Welcome to Orlando Medical Institute Look Back on Airway Management. I'm here today with Mike Hislop, myself, Felix Marquez, and we're here to discuss Mike's four podcast series on airway management.
Yeah, I'm glad we kind of broke it up a little bit, give people a chance to kind of take in really this huge topic.
Well, it is a huge topic, and that's why I broke it over four series.
Yeah.
And the reason why is because airway is that important.
Yeah, it's one of those game changers, right? What separates the EMT level, it's pharmacology and airway management. Really, that's this big separator, right?
Absolutely. Without airway, you have a dead patient.
Yeah,
So
much.
it's something that we have to emphasize. So it was a long series, but a well indeed great series of information. Hope you guys truly enjoyed the airway management podcast. So I want to talk about some certain things and highlight all four series into one look back.
Sure.
Anatomy obviously doesn't change. Anatomy is anatomy, right? The big difference, as you just mentioned, is the paramedic and EMT is the ability to manage not only an airway at a basic level, but to understand when we need to intervene at an advanced level.
I would suggest, you take students in, as we've done for many years, and the physical act of intubation ends up being quite simple. The great clinicians that step to that next level are the ones that know when to.
And when not to.
Right,
and when not to.
Yeah, really making that when to pull the trigger sometimes is the hardest thing. Not necessarily the act itself, but when is this necessary? The ability to look in someone's eyes and say, they're done. We need to take it to that next level. And that's where your experience kind of comes in a lot.
Right, and that's something you'll learn over time, is you'll get with experience. So it's good to have a good foundation so you can build upon that.
Absolutely.
When it comes to the airway management, that's a great point you brought up, is when to do it and when shouldn't we do it. So when you do it, we understand intubation. Let's talk about intubation itself, because intubation is one part of airway management.
Yeah, and some people think that we're talking about air. It's literally a 10% of airway management is intubation. Sometimes 90% of the perfect airways that have saved lives are BLS level, right? It's the OPA, the MPA, the ability to ventilate appropriately. That's your bread and butter, and it's always your backup position, your safe backup position to even the most challenging situations.
Right, and in your podcast series, series 1, 2, dealt with just management airway. As part 3 got into the innovation part. Right. And then part 4 got into, what we could do if we have a patient that needs an airway but needs
facilitate.
to
facilitate.
facilitate.
Yeah. And that's really comes down to a lot of that pharmacology knowledge that's required.
Absolutely.
Certainly.
So it wasn't 100% of airway management was innovation. It's just a piece. And what you guys really need to understand, airway management is just that. How can we best with this patient at this time manage their airway? Yeah. So if the BVM is your way of managing it, then so be it. If it's not, supraglottics, ET tubes.
There's a great adjunct out there. If it's not broke, don't fix it.
Absolutely.
If what you're doing is effective, working, and not going to create distance harm, then maybe that's the way to go. Understand that if a patient has an OPA and they don't have a gag reflex, that's on you. Right.
So then we say to ourselves, then why do we intubate? Well, we intubate because intubation of a patient in our realm of practice, and when I say our realm, pre-hospital, is we don't have the luxury of having our patient NPO, nothing by mouth for 24 hours prior to them dying.
Our patients are on an entire different protocol. They eat the entire right side of the refrigerator just before calling.
Absolutely.
Typically. Yeah.
So we need to know that, because they're not NPO for 24 hours prior to us getting there. There's a high possibility that they're going to have stomach content. So I like to call it the ingredients to create vomitus. And when you have an uncontrollable airway, that vomitus could lead into aspiration.
Yeah, if you wanted to make a slurry of maybe the worst thing you can put in your lung to kill a patient, you would probably take some bacteria-ridden food, mix in some hydrochloric acid, slurry it up a little bit, and quite literally, lung tissue is quite delicate, right? Because it has a finite job to do, and it just can't take this insult without thinking that there's going to be really some negative ramifications.
So the 3 ingredients I referred to is 1 is food, 2 is air, and 3 is movement. And unfortunately, we have to move our patients and we have to ventilate our patients. We're not in a time yet where we could say, hey, Scotty, can you beam us up? And boom, we're in the hospital. No, we have to move them from whatever position they were in, maybe from the floor to the gurney, from the gurney to the ambulance, from the ambulance to the hospital. That's a lot of movement. So that's one of the ingredients. 2 is air. How many patients we come in that we have the ability to say, let's start an IV first, let's RSI them, then we intubate, so we don't have to ventilate. We don't fall in that realm. When we get there is we're probably way behind the ball, so we start ventilating with BVM.
Yeah, we show up late, even when we're on time.
Yes, exactly.
Too often.
Because we can't control the person calling 911.
Right.
So we get there, we're late, we want to ventilate, we have to move our patients. And then the third thing, as I mentioned, is food content. We can't control food content.
No.
So that's the reason why we say to ourselves is we're going to intubate this patient, because that is truly the only device that we carry that can truly secure an airway.
When you live in 2 worlds of you're either safe and secured, or you're over here not safe, not secured, this is a very good spot to be in, right? And everything else is tentative and potentially hazardous and can be harmful, so it's just not a safe spot for us to feel okay.
So I wanted to emphasize on that because he did cover that in his podcast, but I just wanted to say that the intubation, when we choose to do intubation, is because of that reason, is we want a secured airway. Because we're worried about aspiration, we're worried about the vomitus of aspiration. So if that becomes a major concern, then yes, our go-to should be the ET. Then we got to say, okay, how can we best facilitate it?
Absolutely.
Now, if intubation is not, if aspiration is not something we truly worry about at this moment with this patient, then it might not be our go-to.
No.
So I'll give you another example. We have the cardiac arrest patient. We know the most important person on the cardiac arrest patient is the compressor.
Person on the chest, sure.
Right. The more you interrupt that compressor, the less perfusion you have. So in that situation, because I know my compressor is the most important, and I know intubation requires us to stop, I might go with a supraglottic. Why? Because of blind intubation.
Right.
It's a blind insertion.
Now, for the people out there saying, well, look, I know for a fact he's going to be able to intubate his patient, and I will be able to intubate his patient without having to stop compressions.
Absolutely.
Because we got years behind us, a lot of experience. Neither of us would have fit in that category coming out of school.
Absolutely.
Right? And that's who protocols or recommendations are made for. The lowest common denominator with the least experience, because you have to be just as proficient for your patient and save them just as much as we can. So in which case, going to those blind insertions where there's no disruption in compressions has optimally proven in every study to be more effective.
Absolutely.
Right?
And now with technology now out there, such as video scopes, we call it VL. With VL, that's something you probably could, like the air track is a great example. You're able to probably do compressions and drop
I
an
think
ET2.
when this technology becomes more affordable, more commonplace, and certainly has been tried, tested, and proven over a period of time, I think it's going to require AHA to have another look at it and say, yes, we all know the gold standard is endotracheal intubation, but what are you willing to give up to get it?
And actually, these video scopes have become more reasonable price-wise.
Oh yeah, when they first came out, my gosh,
unbelievable. It was hard for us to say, we would never get that.
They were the $900 VCR in 1982 kind of thing, yeah.
So they're more affordable, but
yeah, gosh no.
So I wanted to just emphasize on that with the ET tube. I wanted to emphasize supraglottics. Supraglottics are a phenomenal airway. It's an alternative airway. It's an option you have because it falls in, once again, airway management. If I can't ventilate adequately with the BVM, or I'm worried about me pushing too much air into the stomach and I can't facilitate intubation, then I got a supraglottic that works really well. Because once I get the supraglottic in, I'm minimizing the air going into the stomach.
And supraglottic, we're talking about the iGel, the King tube, the
LMA
LMA.
Supreme,
There's Supremes. There's a bunch of different, again, tools of the trade out there. Some advantages, some disadvantages, upsides, downsides, but they're all similar in the sense that they are a backup airway. And most times, in a lot of services out there, these are even EMT placement airways, in which case, kind of a good steady standby.
Absolutely.
And it's comfortable to have that fallback position. It's like having a reserve chute.
Yeah, with that supraglottic airway, I want to also reiterate that we talked about securing the airway with ET tube. That's the only device we have that will secure an ET tube. But not every patient falls into that category where I could put an ET tube in. So I might have to resort to an alternative tube such as a supraglottic. So with a supraglottic airway, because we can't secure an airway and the recipe's still there, they probably still have food stomach content.
Risk
They probably we still have to move our patient, and there's air. So what could we do to minimize that? Take away one of those ingredients, such as the air. That's where the OG comes into play. So if I drop a supraglottic, put an OG in, now I alleviate the air at the stomach. Now I truly minimize my patient's chance of
I have been of
vomiting.
the belief through my professional practice over a long period of time, have always had protocols that afforded me putting in an OG, but never required me to.
Right.
I think it should be a requirement. I think when you place an endotracheal intubation, I think an oral gastric juice should be placed just as a part of the process. No patient in an ER setting, an ICU setting, inpatient in a hospital can be on a mechanical ventilator without an OG placed.
And
It's
I want to
policy.
emphasize, especially with supraglottic,
Yeah.
especially, and our pediatric
We can
patients.
get rid of bile, stomach contents, some of that acid and bacterial-ridden food, and air out of the belly. And not to do that really is kind of doing a disservice to a
And with
patient, I think.
pediatrics too, you want to definitely, you should have all pediatric patients have an OG or NG. And the reason why is a distended abdomen can actually obstruct the diaphragm from contracting.
Yeah, there's only a
So
finite
now-
amount of space available for
Correct.
them to get that expansion.
So when you can't
yeah.
ventilate, you feel like that you have a ventilator obstructed airway. It could be something simple as a
Having
gastric
worked,
distension.
having worked in the ER setting for a very long time, you listen to that radio and you know a patient's coming in, pediatric patient being ventilated pre-hospital without an airway in. And what the entirety of the staff will automatically do without saying a word is make their way to central supply. They're grabbing an OG, an NG is suction, and they're getting all this stuff because that's the first intervention that's going to be made. Because invariably, this child is going to look 9 months pregnant with the diaphragm up in their clavicles. And we don't even wait for the x-ray to confirm that that's the case anymore. It's almost a given.
Absolutely.
So we're going to ventilate better, but we're going to understand how not to create the process, but also how to alleviate it.
So let's shift gears now. We talked about those different airways of insertion, and he discussed in detail about each one of those devices and how to intubate. So the equipment you needed. So we talked about the blades in part 3. The straight blade known as the Wisconsin blade,
Right,
known
Miller,
as the
sure.
Miller blade. That's a great blade. It's a good blade, but it's a blade that you need to understand. It's a blade that goes directly in and actually grabs the epiglottis.
And pulls up the entire structure, whereas that curved blade, the
Correct.
Mac, is
The
going to go into that
Macintosh.
vallicula. It's got a finite endpoint. And I think
Yeah.
that's where I found a comfort level with it
Me
early
too,
on in
me
my
too.
career.
And I don't want to show no bias to neither one of those.
No.
I'm a Mac. I use Mac absolutely,
Yeah.
but I've been using Mac for over 25 years, so
Yeah.
it's a big difference, So
Yeah.
what my suggestion to you is, when you come to lab and you practice, is try them both, play with them. Maybe your first skill day you should play with both, and then
show
find
proficiency on both before you are allowed to make your selection.
out. And then
That
you
much I promise.
then you figure out, okay, I like this one better, and then focus on that.
Right.
Let that be your focal point. Let
And
that
the
be
rationale
blade.
behind having to show that proficiency in the lab certainly comes down to, as we talked about, those pediatric patients, right? That natural cricoid narrowing, that conical kind of airway. It doesn't require a cuff, in which case you have to also use a Miller on those pediatric
Right,
patients.
and with also that pediatric patient, why everybody defaults to the straight blade, the Miller blade, is, well, we talked about the curved blade. Where does it go in the vallicula?
Yeah.
So it lifts up, it indirectly
It's
lifts up
it's
the
immature,
epiglottis.
underdeveloped.
So when
yeah.
we have an epiglottis that's very flimsy, very proportional, it's hard to control.
You'll
So
actually
putting
create a tear.
blade,
Yeah.
putting a blade into the vallicula to lift up the epiglottis indirectly is really hard to do with a pediatric epiglottis.
It's like
very
trying
flimsy.
to lift up weight with wet toilet paper. It's
So
just gonna
yeah,
rip.
so we
Yeah.
like to go straight with the straight blade, where we actually grab the epiglottis. So if it's flimsy, if it's proportional, it doesn't become of an issue.
Mm-hmm.
So Miller blade's probably the preferred in the pediatrics. So also I want to talk about ET tube size. For many years, and I was trained the same way, that the preferred blade or the default tube is a 7.5, 7.5, and then we might be taught a 7.5, but we always go a half a size less, and for some reason everybody grabs a 7, which it should be the other way around. Your default tube should be an 802.
Absolutely.
802 fits in the 70-pound little old lady,
Mhm.
no problem. Mike,
There are people with smaller airways, in which case we know to practice 1 up, 1 down rule.
Right.
However, an 8 tube versus a 7, it's not one of those go big or go home. It's not a
No.
machismo thing. It comes down to what can an 8 tube offer that a 7 can't?
Well-
Bronchoscopy,
Right.
ventilators that don't give backup alarms, overpressures, the fact that you don't need as much force in order to get that
Correct.
less barotrauma. So there's really upsides in having the right size
and,
tube.
and it's about continuity of care, because we deliver our patients to the
Mm-hmm.
hospital. That's our endpoint, is that hospital. So that patient with an 802, anything less than an 802, when they do put them on that ventilator, the pressures that are set could
Overpressure
cause,
alarms and
right, could
very,
create,
very
it
sensitive.
could create a lot of distal pressure that can cause overtime
Yeah.
damage to the bronchi tissue. So once you come to the hospital, and if it's anything less than the 8.0, they're probably going to look to switch out the tube.
Yeah.
So pay attention to that. If you could put an 8.0 tube, it's about that continuity of care for that patient. Because if you did put a smaller tube and you inflate the cuff, as you mentioned in your presentation, you put 10 cc's, 15 cc's, you can actually overinflate and cause severe damage to the trachea tissue, that when they do pull out that tube, it's going to swell shut. And now they have to stick a smaller tube than what they initially
Or worse,
had.
have to tracheostomy or something, some god-awful procedure based on somebody just not paying attention to the details.
Correct.
Devil's in the details, it always has been. And certainly that's not untrue of airway management as well.
So take a look at that when we're going to talk more about that in the lab, and we'll see. So remember, enough air just to pillow that cuff.
Yeah.
Once that cuff is
I
pillowed,
equate it to
we're
cap
good.
refill, right? You close it, it should come back in about 2 seconds,
Correct.
right? If it looks like a soccer ball, that's too much air, right?
And if it stays flat, then there's not enough.
It's not enough, or you have a damaged tube.
small.
Which is something that obviously we're going to check and surveil our equipment to make sure everything's right before we initiate this procedure. You're prepared, or 100%, or you're unprepared to move forward.
And I want to reiterate too, 100%. Not 99.9%, but 100% tube confirmation is going to be your end-tidal CO2.
Yeah.
So make sure you have your end-tidal CO2 hooked up to every ET tube.
This used to be, even 10 years ago, a luxury.
Yeah.
There was a lot of services that didn't have it. It has become standard of care. And quite literally, I think it's rare to deal with a patient that doesn't have it, at least quantitative. If not even a waveform, I think that's become commonplace. But at very minimum, that numerical value, that gives you that quantitative evidence that you're in the right spot, and remains so, whereas that qualitative years ago, right, it turned purple, it changed color, we're in, it's good, but did it remain in? We had no evidence of that other than, routine assessment, but evidence or proof is better than a statement.
Constantly changing out the colorimetrics to say it's still in.
Proof versus I'll take your word for it. I'll take the proof any day.
Yeah, and so let's switch directions, because I don't want to make this. We could probably sit here and talk about airway for hours.
Yeah, it's one of those topics.
Let's talk about sedation induced intubation.
Yeah.
So
a lot of acronyms out there, right? Drug-assisted intubation, drug-facilitated.
Right. Rapid sequence intubation.
Yeah. There's two different concepts, right? DAI, drug-assisted intubation or facilitated intubation, and RSI. And the only differentiation between there is sedation along with that paralytic, right? Whether it be succinylcholine, Vang, PEC, ROC, you have drugs that can paralyze your patient. Typically, the most commonly used, obviously, succinylcholine.
And let me just touch on that, Mike, if you don't mind for a second. He talked about paralytics. If you're using paralytics, you're RSIing. If you're using just sedation, then obviously you're sedating your patient to intubate them. So when we talk about paralytics, there's a whole bunch of them out there. We have one that's what we refer to as a depolarizing paralytic, which is succinylcholine.
So depol versus repol, just how it creates that paralysis, right? What effect is it? Is it blocking that transmission to the muscle, or is it physically changing the polarity of the muscle in order to paralyze it?
And when you create that depolarization, then one thing we have to keep in the back of our mind is that is going to increase your potassium levels.
Yeah, hyperkalemia is always going to be that contraindication, and very often that understanding now leads us to a filter saying, okay, well, who's hyperkalemic? So we have to understand what subsets, right? Those burns patients, not initially or the acute phase, but 24 hours later, they're going to be fluid shifting. They're going to be having those cell walls disrupt. They're going to be hyperkalemic. The person who's on their way to dialysis or a day late,
has no renal,
the person who's had crush or compartment syndrome, hyperkalemia comes along with those. So we have to have a really, really good understanding of not just surveillance of that T wave, looking into hyperkalemia, but really the story. Because very often, either the acute presentation or what you're being told is going to give you every indication that this may not be the drug of choice.
Right, and because succinylcholine, it's a depolarizing agent, it causes fasciculation where all your muscles at one time will contract. So not only would that spike potassium, it also could increase pressure. So somebody with a significant head injury where signs of severe herniation, we got to take that into consideration as well. Are we going to put them over the edge with that spike in pressure?
And very often using maybe different regimes in sedation can certainly reduce that, as well as something we'll go over in the lab called a priming dose, right? A 10% dose of one of these other rock rhonium brack. 10% of those, it eliminates fasciculation.
So it takes us to what Mike is talking about is the other types of paralytics, which are the non-depolarizing paralytics. So those are your ROC, your PAM, Vecuronians.
Mm-hmm.
So those are the medications that if you give it, it's not going to cause fasciculation. So if it doesn't cause fasciculation, it's not going to spike your potassium, it's not going to increase pressure. So,
I know what you just thought to yourself. Well, why don't we use those? They sound so much better.
Well, that's a great question, and that's what you're probably saying. And let me answer that question for you. The reason why those are not preferred is because we're not paralyzing to perform surgery where we have full control of muscles.
Right.
We are giving a paralytic to just facilitate the intubation.
Which is why that rapid uptake of acetylcholine associated with succinylcholine use, you're talking about a drug that's 5 and 10 minutes,
Right.
and we're not paralyzed
Right.
anymore.
Sux is
Whereas
short
these
term.
other forms of paralytic,
45 an hour.
45 an hour, 2 hours, you know. So typically, and you'll see that even in critical care and certainly within the ER setting, they're likely not to use these longer acting paralytics unless the patient's already intubated. So these are less likely to be used for facilitation of intubation, but more likely to prolong paralysis for a patient who's already intubated typically.
So let me explain those two. So in our realm of practice, in the pre-hospital setting, we don't care to paralyze patients for long-term whatsoever.
Don't need that.
We want to just paralyze them so we could drop an ET tube. And what you're going to learn, it takes a standard time to drop a tube should be less than 30 seconds.
Right.
So anything more than 30 seconds, it's a long time that the patient is paralyzed. So
Yeah.
that's why we choose succinylcholine, because it has a half-life of 5 to 6 minutes.
And that time when your patient goes from we are heavily sedated, we are paralyzed, before that tube is secured, that 30 seconds is going to feel like about 2.5 lifetimes. Because we know that we just took a patient who is at risk of aspiration and just put them at risk for aspiration before we secure that airway. So that is a gap that you should never feel comfortable in.
Absolutely.
Right? Never feel comfortable with that gap.
No.
Right?
So then the non-depolarizing agents, those who likes that? Well, we talk to surgeons. They love it.
Right.
Why? They last long. They're long-lasting. So when they're performing surgery, knee surgery, leg surgery, we don't have to worry about muscles contracting that can complicate surgery. Right. So they're fighting against the patient's muscle. So by paralyzing them long-term, they have full control of muscles where they can perform surgery.
Not uncommon associated with critical care, right? For trauma alerts, you're giving it over to a critical care team or receiving this patient. They're intubated. They were maybe facilitated with succinylcholine. Now is a really good time. Where are these patients likely going? OR1, right? They're going directly to the OR, in which case longer-term paralytics, VEC, ROC, PANC, these are certainly appropriate in that realm, but not typical as far as your frontline EMS.
And I want to reiterate, and this is a take-home point what I'm about to say, and probably very serious, and I wish I could just put alert to this podcast to say that paralytics do not sedate.
No, gosh,
paralytics just paralyze. So if you give a paralytic without sedation, your patient is 100% conscious.
When you describe having that done to a human being, to 6 strangers that are sitting on your jury panel, it's not going to take them more than 10 seconds to realize, my God, this is the worst thing I can imagine.
So make sure we sedate before we paralyze.
And that's why a lot of times you're talking about the DAI protocols or these RSI protocols, it comes out to lead out with that benzo, right? Little sedation, little sleepy, little put out, and now a deeper sedation with your ketamines or your tamidates, or even fentanyl at that point is typically utilized as well. So one of these other drugs is deeper sedation drugs, and then consider paralysis. Right. No, it's always a 3-drug regime, and there's a reason for that. It's insurance or asleep. It's a double insurance or asleep, and before paralysis can even be considered.
And also to add on that too is those are very important, what Mike just said. But also we got to add in there, how quickly I got to manage this airway. Do I have 1 to 2 minutes to wait? I know it's 1 to 2 minutes right now. Talking non-urgent situation that's quick. But when you have an urgent situation, 1 to 2 minutes, as you mentioned earlier, could be 10 to 20 minutes.
Gosh, it's a lifetime.
So we have a drug called Paramedic, very good drug. But Paramedic, what's great about Paramedic is quick acting. 30 seconds, man, boom, patient is done.
You're done.
But the downfall to
drops
that,
your pressure like a rock sometimes. So
and one of the other downfalls is it doesn't last as long.
Yeah.
But it's a very strong and very good sedative drug. So I could get you sedated quickly, but I'm not going to keep you sedated long term.
Right.
So I follow that with maybe a Versed.
We have to be proficient in our skill sets and timely, because we have constraints within that pharmacology.
So I give some Paramedic, boom, patient's out. Follow it with Versed. Versed might take 1 or 2 minutes before it starts to work, but guess what happens in 3 to 4 minutes, 5, 6 minutes?
You're good to go.
Paramedic's no longer active, but guess what kicked in? Versed, which lasts 45 minutes or so. Right. And then we go something strong, as you mentioned. We go into ketamine. Ketamine's great. You know what's great about ketamine? Doesn't drop
Beta
pressure.
drug, right? Beta positive, beta agonist, right?
Yeah.
So it's going to basically increase heart rate, increase blood, as well as get that bronchodilation, which
Yes.
is sometimes really good for those respiratory patients.
Right, the
Especially
asthmatic.
those bronchospastic process.
And that's a
yeah.
great side effect of ketamine is
Yeah,
ketamine
it's
not
one of the
only
upsides.
sedate. I mean, ketamine's a new sexy, guys. I'm gonna be honest.
It is. It really is.
It
Because
is.
so many times we're contraindicated. Whenever we're talking about sedation drugs, we're turning you down, putting you to sleep. And unfortunately, it has that same effect on heart rate and blood pressure. And for hypotensive patients, especially our septic patients or our bleeding patients, we can't afford it, right?
Yeah.
So a lot of these great drugs that we're afforded are contraindicated by your patient. Ketamine is always going to be okay. You know what I mean?
Right.
And I think that's why
Because
it's
ketamine does the opposite of most of those drugs do. It actually spikes
Yeah.
the pressure.
it's unique on an island that way, right?
Yeah,
It
yeah.
literally sits alone.
So
in
it has
that-
multiple
in that.
properties. One, it can sedate you. Two, it's an has analgesic effects.
And that dissociative state, which
Right.
Pete Antevi recently did a study and put it out there saying that the appropriate dose of ketamine certainly here, but when it's used in analgesia, especially in his realm, in the pediatric realm, associated with the right dosing regime, certainly, except put in a bag and given over 20 minutes, a lot of that dysphoria, that dissociative stuff kind of went away, you know, so something certainly needs some more look at. Less likely to be advantageous in our RSI realm because that's all
Right.
about the right here, right now. But certainly there are people that actually have ketamine out there. That's their analgesic of choice,
Yeah.
you know,
Yeah.
and
Yeah, so it also has bronchodilation properties. So I
Yeah.
have this asthmatic whose breathing is inadequate and I'm sedating them. That might be my choice of medication
Oh,
because I'm going to
perfect.
sedate and then I get the second benefit.
anytime you get a second, third benefit
bronchodilation.
out of your drug, you probably pick the right one,
Yeah.
typically.
So we use that, and we talked about the paralytic. So we're going to practice that here at school. We're going to give you some airway scenarios
Yeah.
where you have to think on your feet. And I want you to know you have all the sedatives and all the paralytics at your disposal. So we want you to choose what's the right one.
We're going to teach you
first.
how to build a house. Then we're going to teach you how to build it on a slant, and build it in a hurricane, and build it in a rainstorm,
And give you the
build
tools.
it-
And give you the tools to do
yeah,
so.
Yeah.
So, that's pretty much what I wanted to really emphasize and talk about when it comes to airway. Mike, anything else you want to add?
Lab time.
Yeah, it's a
Work.
practice, a skill.
Work. Yeah, it's practice like anything else.
And that's a great point. It's a skill. So how we get good at a skill? Practice the skill.
Yeah.
Where you practice that? In your skill labs.
You can't memorize how to intubate.
No. It's
Your
a
muscle
skill.
has to memorize it.
And I want
right?
you to
So-
know, I've been doing this 25 years. I intubate quite a bit. I actually do cadaver labs frequently, at least one a month, where we intubate all day.
all day.
And I still consider myself a novelist. I don't consider myself a practitioner. And the
Yeah.
reason why is I don't intubate every day, all day, because that's not my profession. I'm not an anesthesiologist.
Years ago, when every cardiac arrest got intubated, and this was a discussion post that we brought up at ClinCon and did a presentation at ClinCon just last year, talking about the actual numerical, quantifiable reduction of endotracheal intubation in the country. And right now, we're at about 11% of the intubations we had just 15 years ago.
Yeah.
So out of every 100 intubations from 15 years ago, we're now at 11,
Yeah.
right? So it's a real significant reduction.
So you have to rely a whole lot on the skill, your technique. So that's what we're going to master is technique. So my suggestion to you is practice, and when you feel that you're proficient, then you need to practice more.
Right.
So that's our look back here on airway management. I hope you enjoyed the look back, and if you have any questions, I'll see you guys at class, or you can actually email me at fmarquez@allmi.edu. I hope you enjoyed this podcast.
Take care now.